Good afternoon, ladies and gentlemen, and welcome to Heart Masters, Key Moments to Optimize the Heart Failure Treatment, with a focus today on heart rate. This program is sponsored by Servier, and it's also endorsed by the Gulf Heart Association and the Emirates Cardiac Society. And you'll be pleased to know that we have CME accreditation. The program aims to share the best experience on optimizing anti-anginal and heart failure treatments and implementation from the guidelines. And we will be focusing mainly today on heart rate. The webinar will cover the heart failure burden, guidelines on optimizing heart failure treatment, heart rate when heart failure patients leave the hospital, key challenges, optimized heart failure care initiative and program. Heart rate is an important parameter whilst optimizing the heart failure treatment, and we'll have also real live approach to heart failure cases, heart failure management clinical cases. We have two prominent speakers today. Our first speaker is Professor Martin Cowie from the UK. He is Professor of Cardiology, Imperial College London, Chief Physician Scientist, mainly in heart failure. He's also Professor of Cardiology and Head of the Cardiology and Heart and Vascular Department. He is also a world expert on digital health and artificial intelligence, and he is on the Digital Health Committee of the European Society of Cardiology. He is the Associate Editor of Heart and journal JACC Heart Failure, and he's also on the editorial board of many journals. He has published more than 300 articles and has an H index of 78 with 70,000 citations. Our second speaker is Professor Hani Sabou, who is a consultant cardiologist at the Heart and Vascular Institute at Cleveland Clinic, Abu Dhabi. Dr. Hani Sabou trained in Kuwait, his undergrad, and then internal medicine in Sunnybrook, New York. And then after that, he completed his electrophysiology at Mass General. Hani has, as you know, many hats and is an expert in many fields. He's board certified in medicine, cardiac electrophysiology, advanced heart failure, internal medicine, echocardiography, nuclear cardiology, and also in lipidology. And he is currently clinical assistant professor of medicine at Brown University. So Dr. Cowie will start, and then followed by Hani Sabou. A few introductory slides about heart failure, which you've seen this before. It's the most commonest cause of hospitalization in patients over 65. It's a huge economic burden. It involves emotional stress, fear, anxiety, depression, and there's also progressive loss of autonomy. This slide is also a very common slide. As you can see, heart failure is much more deadlier than cancer. Yet, unfortunately, our hospitals and regulators and governments are focused a lot on the screening and treatment of cancer, but not as much on heart failure. 1 out of 4 patients are readmitted within 30 days. 1 out of 3 do not return to work after hospitalization. And ward costs account for 75% of the hospitalization costs, and this is mainly in Europe and the US, although our costs here are slightly different, and up to 75% of these readmissions are preventable. As you can see, the vulnerable phase after discharge occurs in the first 30 days, whether it is for heart failure death, sudden death, and all non-cardiovascular death. Without further ado, I'd like to ask Professor Martin Cowie to start his presentation. Thank you.
Thank you very much indeed. And let me just share my screen and get the slides going. I hope you can hear me all right. Here we go.
Yes, we can hear you.
Thank you. So a great pleasure to join you this afternoon and to discuss some of these topics in the management of our patients with heart failure. And heart rate is one of the cheapest biomarkers around for heart failure. Easy to measure, easy to record, but very important that we can target this and improve the prognosis of our patients. And you've already seen those slides showing the burden of heart failure which is only going to increase in all of our countries as people live longer and have more comorbidity. So it's really important to spend just a few minutes reviewing the data, the evidence, the guidelines, and also thinking about what we can do differently to improve the outcome for our patients. These are my declarations of interest, which you've seen already. And I think the real issue that we have is how can we make excellence the rule for our patients rather than the exception? So it's easy to treat just a very small number of patients extremely well. The challenge is when you have many more patients, often coming in large numbers and very busy, and not you seeing the patients all the time, but other members of staff who may not be as experienced or as knowledgeable. So how can we design our systems to deliver better care as the routine? And often I think it's useful to sit back for a few minutes and think, well, how well are we actually doing at the moment? What do the data suggest? Where could we improve? Where are we doing well? And where do we need to focus more attention? So that's why it's a particular pleasure to join you for our discussion this afternoon, which will include case studies and also a good opportunity, I hope, to think about some of these issues together. Now, sadly, we know that in general, doctors are not very good at following guidelines. Now, some of this is because the patients do not tolerate what we would like to administer or prescribe, but often it's due to either not being aware of what good treatment looks like, or not actually seeing the patient after discharge from hospital to be able to make those additional changes. So in this slide, I've just put together a variety of different data sources and from across the world with large registries of how well we're doing across the world in delivering RAS inhibitors, beta blockers, aldosterone antagonists, and then ivabradine. And you can see that the blue there at the top is patients actually getting to the so-called optimal dosing or guideline-based targets. And for any of the medications, you can see that we certainly don't get anywhere near 100% of patients to that. And for some agents, actually, it's only 20 or 30% of patients. Now, I accept, of course, that you're not going to get to 100% because of comorbidity and side effect issues, but this doesn't really look very good in terms of routine practice. Interestingly, aldosterone antagonists are more likely to get to target doses because there's very few titration steps. So as soon as you fire the drug, as it were, it's really at the optimal dose. And similarly for ivabradine in terms of heart rate control, very few titration steps for most patients. So if you do use it, generally the patients get onto the right dose from the start. Now, why is it important? You might just say, well, the guidelines are a bit theoretical. The patients seem to be doing okay. Well, the problem is that the data doesn't support that. And this is from a recent, very large global registry that Michelle Kamajda and I ran called Qualify. That was supported by Servier. And this is across many different countries. And you can see on the left, heart failure hospitalization or cardiovascular death, and on the right, just heart failure death, that the more adherent the doctor is to the guidelines and these groups of medication, the better the patient will do. And it's really quite a strong effect in terms of improving outcome. So for many patients, they should be asking, does my doctor know the guidelines, and does my doctor and his or her service deliver guideline mandated therapy regularly? Am I likely to do better with this service or with that? And in some countries, of course, there is competition between hospitals on this, and that's why they often demonstrate some of these audit points. But in many parts of the world, patients have very little choice. So it's even more important that the doctors running the heart failure service know the guidelines and make sure it happens day in, day out as a matter of routine. There's no shortage of guidelines, and I'm sure you're all very familiar with them. The European Society of Cardiology will update its guidelines next month, so we look forward to seeing them. But the last version of those guidelines try to focus people's attention on the phase of the patient going through the healthcare service. So the immediate phase when they're admitted to hospital, obviously you're trying to save their lives, get them stable, and make sure they're in the right place in the hospital. But then very rapidly you move on to the next phase, which is working out what's going on introducing drug therapy and trying to optimize and titrate that up before discharge is a really crucial time point. This is for right across the world. What are you trying to achieve? When's it going to be achieved? Who's going to see the patient? Who's going to do this? Otherwise, the patient will end up most likely on suboptimal doses, poorly controlled syndrome, and is going to be readmitted, as you've seen in the previous slides, or to die. So it's really important, this pre-discharge back out into the community as to what the plan is and who's going to do that. And I'll touch on a program I was involved with and helped lead called the Optimize program, where right across about 40 different countries, we try to have simple tools to focus people's attention on these key points. Now, none of this is rocket science. None of it's particularly complicated. The challenge is operational. How do you make it happen? And how can you demonstrate it's actually happening? This is a slide I've just put together to show the impact of various programs on introducing drug therapy and up titration. This is looking at the effect of hospitalization. Now, it's got all the different classes of drugs. It's quite complicated, but if you just look at the blue arrows, you can see for each of these programs, it does vary a little bit, but hospitalization is the ideal opportunity to up titrate medication, to ramp up the therapy closer to what would be optimal for that individual. And if we're not doing it whilst they're hospitalized, we've missed a golden opportunity to improve the quality of their care and the outcome for that individual. So I think it's an ethical imperative for us, for every patient coming into hospital, to review their treatment, to make sure it's optimized and have a clear plan of how we're going to further optimize after the discharge. Now, I know it's difficult, particularly if you don't see the patient yourself after discharge, but these are the challenges our healthcare systems have to solve if we're going to improve the situation. The other point that I've often come across around the world is that people think that if they get the right classes of drugs into patients, then the job is done. But I think a lot of registry data shows that, particularly in hospital, it's impossible to get the patient really optimized for the long term. So here's a study from the States, the Optimized Heart Failure Registry with almost 11,000 patients, many different US centers. And you can see, obviously, if you've got no beta blockade at all, then the heart rate is higher. But even if you get up to 50, 75, 100% of the target dose, about half of the patients still have a heart rate well above 70. And you can see that on average, 70% of American patients were leaving hospital with a heart rate and sinus rhythm above 70. And we'll come back to that 70 and why it's important. So even with the best will in the world, even with the most optimization you can do in hospital, you're still leaving the heart failure syndrome suboptimally controlled when they're leaving hospital. Further work is definitely needed to improve their therapy. So a little bit of a top line about the Optimize program, and I'll come back to it toward the end of my talk with a little bit more detail. This is not complicated. It was designed to work in very different healthcare settings, so to keep it straightforward and not expensive. And it was really looking at the components of care. So this optimization before discharge that I've mentioned and emphasized, very important to have a protocol in the hospital for this is heart failure, this is how it should be managed. These are the drugs we're trying to use. This is the things you should measure in terms of blood tests and vital signs. And then this checklist, which was given to the patients, either electronically or in paper format, depending on the country, which clearly states the current medications, what the current vital signs and bloods looked like, and what the plan was in terms of up titration. Patient would carry that to their follow-up appointment, and even if it was a different doctor, just by handing that over, the doctor could read through the form very quickly, and even if they didn't know a huge amount about heart failure, they were educated within seconds to what should be done, what the targets were. So without any embarrassment or loss of face, that doctor would then be upskilled very rapidly. Patient was happy that the plan was being followed and everybody knew what was happening. So it's, once again, not rocket science, but it was enormously effective, just a simple concept of a pre-discharge list to then be carried forward in the program. And then underpinning all of that was education for the patient and their family. So even though the patient might be very elderly and not very engaged in this, often the children or grandchildren wanted to know more, wanted to know what they could do to help. So we had a passport, which was paper or electronic, and now we have an app where you can actually support people with education for them to know what the important things are. Right across the world, 44 countries at the present time. So experience we've gained over the last 5 to 10 years in this program has really highlighted some of the common themes, the barriers, obstacles, but also the easy solutions. And I'll present some of them briefly at the end of my talk, just to throw into the discussion. Obviously, even across the Gulf, the countries are very different challenges, but some of the challenges are very similar. So hopefully that will be helpful in our discussions. Some years ago, we published this document, which was about the policy changes that needed to be done globally about heart failure. And I'm just going to pull out 2 of the 8 that we published in this document, which has been cited thousands of times. And that's about care transitions and optimizing them. So either coming in as an emergency to the emergency room or critical care unit, and also coming out of hospital back home and the follow-up there. Those are the 2 points where often things aren't done as well as they should be. The other thing I've highlighted there is, for you that are watching this, you are the experts in heart failure to lead this. Without you driving it forward, it's not going to happen. So it's that human factors and the championing of heart failure that's hugely important. Now, let me just share you a little bit about in the UK what we've experienced over the past 20 years. And I helped set up the British Society of Heart Failure when heart failure had little profile in the UK, very little resource and very little focus. And we've made huge strides, but have still so much more to do. But I just wanted to pick out a few points which might be helpful in our discussions. So if you look at the chart there, I've got on the left is a specialist input in the use of drugs from 2011 through to 2016, and then on the right is with no specialist input. And it doesn't matter what class of drugs. If you see a specialist, that was a cardiologist or a heart failure physician, then you are very, very, very much more likely to go on to life-saving therapy. It kind of makes sense. You've seen the person who knows about heart failure, they know what the drugs are, and they're more likely to prescribe them. There's a slight trend upwards for the more general physicians to use these drugs, but still so much less. And that's why the UK government has said that every heart failure patient admitted to any English hospital must be seen by the heart failure team, irrespective of whether they're on the care of the elderly ward, the GI ward, or the cardiac ward. There has to be input, because if you see the specialist, you're much more likely to get the proper diagnosis and onto the right treatment. A report was done, a national audit of this by the National Confidential Inquiry, and this committee looked at every hospital and patients who died with heart failure within those hospitals. Obviously anonymized when it comes to the report, but there were some very strong themes, and it'd be very interesting in our discussion to see if there are also themes across the Gulf states. So it's about access to the specialists, which can be problematic unless you really focus on it. Also, lack of discussion of how aggressive the treatment was going to be and if there was any ceilings of therapy, which is particularly appropriate for very elderly patients with multiple comorbidity. And that lack of discussion with the patient, with the family, with the caregivers in hospital often led to problems later on, and often in the middle of the night or at the weekends when less people were around. Investigations were ordered very rapidly, but often not done very quickly, and access to echo was one of the key tests, which has been a challenge, particularly out of hours in UK hospitals. I'm sure I'm very much better in the Gulf. And then also the fact that some teams didn't seem to have a guideline. They didn't really seem to know what good looked like. And that's all been resolved with NICE issuing guidance for the NHS on acute heart failure as well as chronic. The other issues on the right-hand side, and this is what I've been alluding to several times, this lack of follow-up after discharge. So what you do in hospital is what happens for the rest of the patient's life. Now, it makes it really important, those of us based in hospital, we get it right and try our very best to do as much as we can. But also, if there is a possibility to follow follow up the patients, please do it, and do it soon rather than a long time. And here it's by different age bands, and the oldest age band is at the bottom, the youngest at the top. And you can see at that point in England, only about 80% of young patients with heart failure were followed up by cardiologists. And it would take probably around a month or 6 weeks before they were seen after discharge, which is hopeless. It's too late by then. Often they would have been readmitted, and the changes had to be done earlier. If you're more typical of heart failure, and the average age in the UK of a new patient being admitted with heart failure in a hospital is 83 years of age, so right down at the bottom of that chart, you can see that that time only 20% were followed up by cardiology. And that would take many, many months. So we've changed the system and made it mandatory for every patient to be seen within 2 weeks, or at least have contact within 2 weeks, whether it's a heart failure nurse specialist in the community, the GP checking on them, or a consultation remotely during COVID, or face-to-face in a clinic. So the standard has been shifted because of the data and because we could see that it was a problem. What about the international recommendations, just to reassure you that you're completely up to date? And as I've said, these are updated all of the time from many different countries, and generally all say more or less the same thing, but using different words depending on what's culturally appropriate. So, you know, the ESC guidelines up till now, but they will be updated to add in SGLT2 inhibitors, we'll come back to that, is very straightforward. And we have ACE inhibition, beta blockade, aldosterone antagonism, that's been around for decades now. But if the patient's still symptomatic, it's obvious reduced ejection fraction, then on the bottom you can see the 3 panels. So ARNIs, is sacubitril valsartan, very much seen as probably the front line RAS inhibitor for such patients. Device therapy, including CRT for bundle branch block patients, particularly broad left bundle. And then here, what we're focusing on this seminar is about heart rate control. If you haven't got your heart rate down in sinus rhythm at rest to 70, that indicates higher risk, higher likelihood of death, higher likelihood of decompensation. If you haven't managed to control it, then ivabradine, very important, is a tool to go in, and all it does is control heart rate and help drop that back down towards that magic figure. So that is the algorithm. The problem is delivering that in routine practice. There's tables to go with this, and I'm not going to read through this slide, but it's grading of evidence, and obviously ACE, beta blockade, and aldosterone antagonism, lots of trials, lots of support for that. Ivabradine with the SHIFT study there for control of the heart failure syndrome in sinus rhythm for those with a resting heart rate above 70, and we'll come back to that. In terms of the American guidelines, this is ivabradine here, 2A evidence here, emphasizing the hospitalization benefit in stabilizing the syndrome and looking at a mix of therapies. And if that mix hasn't controlled the heart rate, then ivabradine is central to do that for sinus rhythm patients. Remember that ivabradine has no effect on heart rate control in atrial fibrillation. That's updated by various documents, and this one is by Dr. Bat. You've probably seen it in JACC 2017, really focusing down on this heart rate control. So you initiate and up-titrate beta blockade as best you possibly can. If you've achieved the maximum tolerated dose and the heart rate is still 70 or above, then ivabradine should be used. And to my mind, it should be used. It's not a theoretical concept. Heart rate's easy to measure. What is it doing? If it's above 70 at rest, you haven't finished the job. Get on and finish the job for that patient, particularly since ivabradine is so well tolerated. It's an easy thing to do. Of course, therapy has moved on, and the great new kids on the block are the SGLT2 inhibitors. And we have 2 very positive studies, in fact more now, DAPA-HF and EMPEROR-Reduced are the key ones, showing the benefits for heart failure endpoints, adding that to those therapies. So it's now become a new pillar of therapy for our patients. It's very exciting, but it doesn't mean that we forget about RAS inhibition or beta blockade or ivabradine. This is an additional tool to be used, an additional pillar to help optimize the outcome for our patients. Now, the big issue, and I think the ESC guidelines will try and help with this, and certainly in many discussion forums, the problem is that people don't get down through all these steps of therapy. The algorithm gets longer and longer, and they get less and less attention as time goes on. So very few patients, as I've shown you, actually get all the way down to the bottom. They almost fight their way through to get onto good therapy. So I think we need to change the mindset, and John McMurray and Milton Packer and others have put papers out there to get the discussion going about what they call rapid sequencing. But to pick up the points, the first presentation, if this was cancer, you wouldn't talk about conventional therapy and rapid therapy. You would just talk about best therapy. So John's suggestion, I've discussed this with him, is a bit agnostic to which goes in first, but basically try and fire in agents early. So he would generally use a beta blocker and SGLT2 inhibitor from the first moment. I'm saying ivabradine in addition. If the beta blockade isn't tolerated, you'll have to use it. If it is tolerated and you don't get the heart rate down to 70, you will have to add it. And then rapidly trying to get the other agents, because it's the 5 pillars to improve outcome. How can you get to those 5 pillars as quickly as possible? And their suggestion is, instead of 6 months to work your way down here, we should be doing it a lot faster and try and get patients onto these agents by 4 weeks. And certainly if I had heart failure, that's definitely what I would want to do, because some of these agents work from the first tablet. The effect is almost immediate. So that gives a sense of urgency. So what about heart rate control in this modern era? How important is it? Is it still important to measure, still important to think about, still important to target to improve outcome? So let's look at some of the data. This is a quite recently published paper by Kevin Doherty in 2019, and he and that group looked at the Paradigm study with Entresto, but also Atmosphere with Aliskiren, and saying, this is modern patients with multiple therapies here. What's the relationship within these people between heart rate and outcome? And it's exactly as it was before the sacubitril valsartan, before the DAPA era. You can see the very strong and well-calibrated relationship between a heart rate at one point in time, just measured at one point, tells you about the future of your patient in terms of risk of heart failure, hospitalization, and cardiovascular death, right from the early period through to 2.5 years. So heart rate is still a very important and inexpensive biomarker that we should be measuring, should be recording, and should be thinking about as a target for therapy. Just to give you a little bit more detail on that paper, don't worry, it looks complicated, it's not. In the SHIFT study, we saw the same effect. On the left is that Doherty paper again, but looking at a wider range of endpoints. The blue dots are sinus rhythm, red dots are AF. And as I've told you, in AF, heart rate, if abradine's irrelevant, heart rate doesn't seem to associate with outcome. But for sinus rhythm, the blue dots, doesn't matter what endpoint you look at there on the left, as your heart rate is higher, that endpoint is more likely to occur. So we know this. Patients also kind of connect with this, and they know that if their heart's going quite fast, if it's slower next time, they're quite happy, and they can often measure it themselves and say, great job, doctor, my heart's now going at a nice, slow, regular rate rather than banging away. So the data support that, even in the very, very recent data analysis. And just to briefly remind you, because I know you're very familiar with the ivabradine data, this is a drug that goes in and it just acts in humans on the sinus node. It only works in sinus rhythm. It drops the sinus rate, and it's rate related. So the higher your resting heart rate, the larger the drop. So it's a kind of inbuilt safety mechanism. If you're going at 80, you might be lucky and get 10 beats reduction. If you're going at 95, you might get 15 or 20 beats reduction. It's just the way the drug works. But more importantly for you and the patients, look at the risk of hospitalization for heart failure. It goes down very rapidly, very unlikely to be due to chance. This is the heart rate effect, 26% reduction. And bear in mind the patients going into the SHIFT study were at specialist centers and were very well treated. It's not just the first admission, It's for the second and the third admissions, they're also reduced. So basically, it controls the heart failure syndrome better. If you look at dying from pump failure, which is a pretty miserable way to die, that impact is almost immediate and reduced by 26%. So I think this is something that is worthwhile doing. Interestingly, the higher your heart rate, of course, the higher your risk. And if you take up instead of 70 to 75 beats per minute, as been done by some regulators across the world, everything is highly positive, including even all-cause mortality. So the higher the resting heart rate and sinus rhythm, sorry, I keep saying the same thing, but it's just to emphasize it, higher the worse the prognosis and the more benefit you can do by getting better heart rate control. I think I've told you this already. The other thing that's really interesting, of course, and very important to our patients and the family is, well, okay, it reduces the risk of being back in hospital. That's important. Might make me live longer. For some people, that's very important. But will it make me feel any better, doctor? And we looked at this in detail in the SHIFT study, one of the first large randomized trials to do it, now being copied by all of them now. And we'd used the KCCQ quality of life questionnaire. The higher the score, the better you're feeling. And we just plotted this by the heart rate reduction in the SHIFT trial. And as such, a clear linear relationship. So from that blue line upwards, this is reduction in heart rate in the trial. And you can see that 80% of patients in Aberdeen had a very meaningful shift, improvement in quality of life. And the more the heart rate drops, the greater the improvement. And some of these patients are getting 8, 9, 10, 11, 12-point improvement in KCCQ, which is massive that they would certainly notice across their life. So it's not just heart failure hospitalization, it's not just cardiovascular mortality, it's also they feel better. So another good reason to discuss this. Many people have asked over the years, what's the mechanism of benefit? And obviously you can understand the energetics being better for the heart with a slower heart rate. But how does the heart respond to that? And Claude Tardif from Canada took the lead on this. And we did the core lab and we did lots of patients, really hard work to do this, looking at what happened to these ventricles once you slowed the heart rate down with adding ivabradine. Now, bear in mind, many of these patients had heart failure for years and had been on good background therapy for years, and then you're adding this late on in the day. And what was very clear is that adding placebo makes no difference on average in terms of the size of the left ventricle. But with a better heart rate control with ivabradine, you got an average 7 mils per meter squared reduction in end systolic volume index. So really important change, and that was the average change. And here I've plotted that change and reduction in size of the ventricle by a cut point of 15%, which is what we use, for example, for CRT therapy, a marker of success. So if you look at the left-hand side there, this is looking at these patients with ivabradine being added, what proportion actually had a really big drop in the size of the left ventricle at end systole. And you can see it's 40% in those on ivabradine versus 25% on placebo. And of course, you might argue, why do the placebo patients improve? Probably because closer care and attention, probably better compliance with their background meds. But you can see that difference between the ivabradine and placebo arm, really substantial. 40% of your patients with chronic heart failure, better heart rate control, having a meaningful reduction in LV size, I think is something that's really therapeutically sensible and exciting. Now, the other thing I would like to say, and this is my experience over the years since the SHIFT trial was published, which is now 10 years ago. It's hard to believe it was 10 years ago, but lots of physicians said, oh, well, that's fine. That's fine for those doctors that don't treat their patients properly. They've got high resting heart rates. That's great. But it doesn't apply to my patients because they all get excellent treatment. Their heart rates are all very well controlled, and I'm not going to change my practice. So the only way I was able to kind of counter that was to say, okay, I'm going to look at my own practice. I'm a professor, I've got 5 consultants, I've got 3 specialist nurses, I'm in London teaching hospital. Surely I can be doing a good job, albeit in quite difficult patients. So I looked at this. This is my hospital here, the Brompton Hospital. Average age of my patients much younger than typical heart failure in the UK because we're at specialist centres. It's only 65. lots of men and women, lots of comorbidity, diabetes, coronary disease, as you'd expect. And we took 100 patients with reduced ejection fraction heart failure. What we found was that 20 of those 100 couldn't take a beta blocker at all, either because they were so hypotensive or because they had asthma and were actually wheezy on a beta blocker. So if we look at those that can tolerate a beta blocker, how well did we do? Well, of those 80, 17, we could only introduce it and we couldn't get it any higher despite trying to titrate up because of side effect problems. 15 got to middle dose, but we couldn't push any higher. 22 flew through right up to the full dose without any problem. And then there was 26 who were still in the process of up titrating. So the next slide will show you the heart rate control I managed to achieve in my specialist practice with these patients. And I'm sorry to say that half of my patients still had a heart rate above 70. Now, I'm sorry to say that because I would like it to be better, but it gave me an ideal opportunity to introduce ivabradine to get that below at 70. 20% of the patients were actually going faster than 80, so that was the highest risk group. And the slide with the distribution of heart rates, I've split by those who could take beta blocker and those that couldn't. And if you look at the blue color there, these are patients who couldn't take a beta blocker at all, and virtually all of them are faster than 70. Why would they be slow? You're not giving them any heart rate modifying therapy. So if you can't tolerate a beta blocker, virtually all of them need to go on ivabradine as soon as possible. If you can tolerate a beta blocker, and that's that orange color on the slide, you see some patients get a lovely slow resting heart rate, and that's excellent. They're going to do very well. But the highest risk group actually are those orange colors on the right side of the red line. So despite optimally, maximally tolerated beta blocker, they're still going faster than 70, the highest risk group, and that's where ivabradine should be added to the beta blocker as soon as possible to get better heart rate control. More data, though. This is from North America, from Rob Mentz, who's now the Journal of Cardiac Failure editor. And this was saying, why don't we start ivabradine in hospital instead of waiting for that first visit afterwards, which may never occur, or waiting 3 months when the next visit might be there. And what they found, of course, was that if you started ivabradine in hospital, you were much more likely to be on it 6 months later. Some people stopped it or didn't take it long term, but you were 4 times more likely to be on it at 6 months if the cardiologist started it in hospital, which I think is a very good reason to get in there when the patient's in front of you in hospital. And for those patients, of course, there was a huge difference in their heart rate control. So usual care versus ivabradine before discharge, 17 beats per minute difference at 6 months. 17 beats is a huge difference in terms of outcome. So I think making the point that even although there's not a trial that specifically looked at ivabradine initiation during hospitalization, it's something easy to do. Drug is extremely well tolerated with millions of patients treated with it, and you will get much better heart rate control from the get-go, and that will be maintained, if not even enlarged, by 6 months' time. So that's why in my practice, we start it when the patient comes in. We see what drugs they're on, we see what their heart rate is, we have a plan, and we get on and do it, because if we don't do it, nobody is going to do it. So the final part of my talk, I think I'm on time, is about how do we make this happen. We have the theory, we have the guidelines, we've got other people's experience, but how do we actually make it happen in our own hospitals and our own clinics and our own countries? And this is where the Optimize program came in, saying to people, you don't have a lot of additional resource or manpower to do this. How can we design a program that's simple but effective? And so over the years, we've learned what works and what doesn't work. And let me just give you 2 slides on this. The first one is about the barriers. And of course, as physicians, we love talking about barriers. The next slide is actually probably even more important, which is the solutions, the kind of key things to drive it forward. But I'm sure you recognize these things on this slide. You will have them in your own services. That's the lack of awareness, the lack of political pressure behind making heart failure better. The few specialists in this area, which is increasing, and a lot of trainees are now more interested in heart failure, but there's still not that many heart failure cardiologists. and the difficulty in providing early follow-up, making it so important to make sure that the hospitalization episode is used for maximum benefit. And poor communication between the hospital and the follow-up services, whether they're general practitioners, other cardiologists, or just other physicians. That's lack of communication that discharge communication sheet really did help with, making it simple and involving the patient and their family. These are the obstacles to getting good care into routine practice. But the things that we found that worked, and you might like to consider this. I know some of you are already doing many of these things. This is about getting local support within a hospital, within a country, within a region, about experts leading this, saying this is what good looks like. We're not there. This is where we should put our efforts. A large part of that is education about the fact not only that it's a serious condition, but that you can make a huge difference if you treat it seriously and give people access to modern therapy. It's increasingly multidisciplinary. It's not just cardiologists, it's pharmacists, it's GPs, it's heart failure nurse specialists working together to maximize outcome and also the experience of care with living with what's quite a frightening condition for the individual. And this integration between hospitals and community post-discharge is really key. And where that happens, you can see enormous improvements really quite quickly. And keep it simple. I think a lot of experts feel that if people are confused by them or impressed by their level of knowledge, that that's all you need to achieve. For me, the best expert is somebody who can make something complex seem simple and enthuse people to say, yes, you can make a difference. It is possible. Let's do this together. And that's where the real world evidence backs up the trials and the guidelines, etc. So here's a great program from Russian-speaking countries from the previous Soviet Union, and they did a program across hospitals. It was resource poor, but they managed with the program to increase the use of Aberdeen, get much better heart rate control, and their real life data shows a 50% reduction in events, either hospitalization from heart failure or death, over a follow-up of just about 12 to 18 months. So very rapidly, that program demonstrated its value, and we published that in the International Journal of Cardiology. So thank you so much for giving me so much time, actually, to present. I'm sorry I can't be there in person, having been in Dubai many times and also traveled across the Kingdom of Saudi Arabia and had a really good time interacting with cardiologists there. But these are my take-home messages from this virtual webinar. I think there's no debate about what good treatment looks like. The guidelines are all there. But patients across the world are slow to be diagnosed, undertreated, and underdosed. So they have shorter lives, more time in hospital, and poorer quality of life. So we have to do a better job. And if we don't drive that, nobody else will. I think the message in this seminar is that heart rate is easy to measure and record. And if you have it in your mind that you need to control this, your patients will then have a better deal because you use beta blockers better. You will use Aberdeen more often and get the heart rate down. So work harder to go lower is the kind of jargon phrase from that. And the key point is that most cardiologists are very hospital-based. That's when you have most input to patients. Then is the opportunity to optimize therapy rather than waiting for this slow 6 months of up titration, which we know doesn't happen, won't happen, and our patients don't do so well. And the final point is, if you and I don't do this, nobody else will. So I'm afraid it is our responsibility to do that. And with that, I'm going to stop sharing my screen and hand you back to our chair. Thank you so much.
Thank you very much, Professor. Our next speaker is Hani, who is going to present some real-life cases. Go ahead, Hani.
Thank you very much, Dr. Wild, for the introduction, and also Professor Cowie for that outstanding review. So we're going to try and look at how we apply these important concepts from a practical standpoint And also we'll try to address how you can actually see this in your clinical practice using echo as a function of reverse remodeling. So it's fairly clear that heart failure is something that's been going on for decades. And one of the important things that we failed to recognize in heart failure for a long time until beta blocker studies were initiated, that it was due to increased adrenergic activity due to the counter regulatory hormones and the increased adrenergic drive. Now, we're all familiar with the definitions of heart failure. It's a structural or functional abnormality. And of course, this is the new universal definition. Some of you may have actually seen this. It's actually been published in EHJ just a couple months ago. It's a combination of signs, symptoms, BNP, in order to include patients with reduced and preserved ejection fraction. Our focus today, of course, is going to be about the HFrEF patient. This has been shown before, but it's really important to emphasize that the rapidity of progression of heart failure and our failure to treat patients, inertia, is horrible, and we're doing a lot worse than most of the cancers you see listed here. Our oncologists, and this analogy was very well said by Professor Cowie, you wouldn't wait if your patient had cancer. If you have a disease that's worse than cancer, why are we waiting? Why are we missing the diagnosis? What's the problem here? So it's a 50% mortality in 5 years. And of course, the opportunity arises when the patient comes into the hospital with a new onset of heart failure or worsening heart failure, because if you don't treat that patient quickly, within less than a year, about a quarter of those patients are going to be dead. But even the patient who was so-called in the stable phase C heart failure, who is in the outpatient clinic, still has a 6 to 7% annual mortality that accrues over time. And we have medical therapies that have been shown to be very effective in this case. So one of the, should I say, philosophical or practical questions, what's the best time to regulate heart failure in the heart failure patient? Is it pre-discharge? Is it post-discharge? Or why are we waiting at all? Heart rate is related to mortality. Why are we not addressing it as soon as we see the diagnosis? And I think the point well taken from Professor Cowie is that pre-discharge is an excellent time to eliminate this risk. Now, heart rate is a vital sign. There is no excuse for not knowing the heart rate in a heart failure patient, in a cardiology patient, in a diabetes patient, in a headache patient. And in fact, it's pretty clear that these patients at the time of hospital discharge who have an increased heart rate had a 41% increase in death. So all over the patient's chart, you're going to see that the heart rate was 90, 95. We're not hitting these numbers, and we're missing a 50% or more opportunity to reduce death rates by addressing heart rate in the heart failure patient. And of course, one hospitalization inevitably leads to another, but the first hospitalization is the onset of a steady slope by which more hospitalization accrues more risk and more mortality. So this is sort of a cartoon I brought up, and I think it's very important because when we're in the hospital, we're focused on congestion, is it not? We're always focusing about the Lasix dose and how much and when are we going to transition from IV to oral. But this is a problem. This is a myth in heart failure. And I wrote it in English and Arabic just for my edification here. It is a mistake to imagine that diuretics will treat heart failure. Diuretics only treat a very small component, and that is congestion. Mortality has no relationship to diuretics. The treatment of heart failure and HFrEF is not about fluid management nor diuretics. Diuretics do not save lives, and the heart failure patient is not a water tank. So by adjusting diuretics, we're doing a small favor to the patient, but we're missing a massive opportunity to treat other things. So we don't have time for an audience response, but really, in practical sense, how many of your patients in clinical practice actually do achieve titration of beta blocker to maximum dose? 10, 50, 90? And how many patients achieve a heart rate of less than 70 in your clinical practice? 10%, 50%, or 90%? So just so you don't feel bad about this, this is actually a study from Boston, from the major academic centers. This is the Partners Network, which includes all the Harvard Medical School hospitals, all of their heart failure patients. This is a recent publication reflecting modern therapy. At the baseline, 36% of patients had a controlled heart rate, in green, less than 70. The majority had a heart rate more than 70, and this is in Harvard Medical Schools. 8 years later, the same 30%, 37.7, had a heart rate less than 70, even though the guidelines are very clear, and the majority, almost 75%, had a heart rate greater than 70. And in fact, this is also after they looked at beta blockers. The only thing that changed over the 8 years of this study is that the number of patients who were not on beta blocker went from 12% to 7.1%, but the overall was not controlled heart rate. Is this important? Yes, it is, because those patients who had a heart rate greater than 70 with high dose of beta blocker or not high dose of beta blocker had a significant increase of their all-cause mortality as well as hospitalization. So this is a very significant point, and it's been made very clear that remodeling and progression of disease is driven by RAS activation as well as neuroadrenergic activation. And of course, you're very familiar with this process of remodeling. And of course, the hemodynamic alterations, neurohormonal activation causes more fibrosis and hypertrophy and matrix damage. Not to forget RAS blockade. RAS is incredibly important. And now we have the addition of neprilysin inhibition in heart failure because of the reduced ejection fraction, reduced cardiac output. There's a tendency to vasoconstriction and hypertrophy, which is driven by the angiotensin II receptor. This is a bad counteractivation. And therefore, we have to block the RAS. At the same time, we now have an opportunity since the paradigm study to augment neprilysin and rebalance the system by blocking angiotensin II with the ARB component and increasing neprilysin, which improves vasodilatation as well as knocking down the vasoconstriction fibrosis. That is valsartan sacubitril. Now, what about heart rate? So heart rate is a critical vital sign, but pathobiologically, it leads to more atherosclerosis, ischemia, remodeling, and heart failure. Heart rate in patients with reduced ejection fraction has been demonstrated for decades, and also more recently to be directly related to mortality. And this study is from 2016 and may not have reflected the updated guidelines. The study from Boston I showed you is more recent, 2019, reflects all of the changes in guidelines that we have seen. Sympathetic activation is always bad because it increases myocyte damage, direct cardiotoxicity, arrhythmias, oxygen demand, as well as activation of RAS. Now, ivabradin's mechanism is quite unique. It does not act on the noradrenergic system. However, it acts on the IF receptor and therefore causes pure heart rate reduction. By slowing down the heart rate, the slope of diastolic depolarization is reduced. There is more time for coronary filling. There's more time for diastolic relaxation. There is more time for the myocardial energetics to improve. And of course, in combination with beta blockers, has been shown to have significant impact. Now, we've kind of pointed this out in many ways. In the clinical course of heart failure, patients will have one dip, the first hospitalization, but they can have sudden death at any time during their time course, as well as decompensation, as well as pump failure. So it's very important not to regard that, we've been successful, we've reduced congestion, the patient can go home. No, this patient is now at very high risk of cardiac arrest, sudden death, or mortality. And this is just to remind us that patients with mild symptoms, functional class 2, but have mild reduction of physical activity, in other words, cannot go up one flight of stairs but do not feel congested right now, are at significant risk of cardiovascular events. Heart failure and sudden death can occur suddenly without warning. And we have to avoid this lethal inertia. Sudden death is more common in functional class 2 patients. Patients with less symptoms are not safe from sudden death, and therefore life-saving therapies need to be intensified and combined as soon as possible. 51% of patients considered stable with functional class 2 symptoms had a cardiovascular death as their primary event. And also remember that 5% of patients receive a change of any of their treatments. And that has to change because we need to move these patients to a more safe location. The European Society of Cardiology and the modified approach was very nicely described by Professor Cowie. This is the 2021 update from the American College of Cardiology heart failure guideline. And there's a tremendous emphasis now on role of evidence-based combination therapy being applied early. Now here, it's very clear that ARNI is in the top line, preferred to ACEs and ARBs unless patients have a very specific contraindication. But then you have the addition of aldosterone antagonist, SGLT2 inhibitor, ivabradine for patients with elevated heart rate in sinus rhythm. And as was now proposed, it's very important to try and administer these medications simultaneously, not one after the other, because time is running out. So here's a real case, and this was before these guidelines were changed. This is a 2018 patient. 47-year-old lady with postpartum associated cardiomyopathy and prior admissions with heart failure transferred to our hospital for volume overload, ascites, and dyspnea. She was actually diagnosed with preeclampsia in her fourth pregnancy, 2013, overt heart failure, reduced ejection fraction 3 years earlier, but was poorly compliant with medical therapies. So she had low-dose carvedilol, low-dose lisinopril, digoxin, spironolactone, and high doses of diuretics. Functional class 3, low blood pressure, tachycardic, very high NT-proBNP, over 6,000, is actually referred to us for discussion of ICD, advanced therapies, LVAD, or heart transplant. Now, over a long ICU and hospital course, the patient was actually finally transferred off inotropes into the ward and started on metoprolol, ivabradine, and low-dose valsartan sacubitril. Notice we're actually doing this in the hospital with very clear guidance to the nurses for follow-up. We actually stopped the digoxin, kept her on the other medications. By the time she was ready to discharge, her BNP dropped from 6,000 to 700. First clinic visit 1 week post-discharge, heart rate still 81. We increased the valsartan sacubitril. We increased the metoprolol. She was still on ivabradine 15 BID. Second clinic visit after the second week post-discharge, 110/72, heart rate still 77. We maximized the valsartan sacubitril, increased the ivabradine, actually started to decrease the furosemide, kept her on the other medications. Now I'm going to show you these images side by side. This is directly from the workstation. I've just covered the patient's name for privacy. Look at the echo in 2018 and September 2019, just less than a year later. The ventricle has shrunk. This is the apical views. Again, the ventricle massively dilated, has shrunk as well. And the four-chamber view. So there can be no mistake that this patient had reverse remodeling with aggressive early medical therapy. And this is her ventricle dimensions, 2019 and 2018. EF is 17%, and ventricular volumes, massive ventricular volumes. You can see the massive change. So there begs the question a year later, and even though we saw the improvement even earlier, does she need an ICD? And the answer, absolutely not. We've achieved a tremendous reduction, and I don't think this patient can legitimately be called postpartum cardiomyopathy because her last pregnancy was over 5 years before. So in early follow-up, again, we were able to up-titrate the metoprolol even further. The furosemide was decreased to 20 milligrams every other day. And just for your interest, we did the echocardiogram, of course, every few weeks because we were trying to see whether she needs an ICD. And at this point, her RV function has also improved. Her ventricle dimensions has shrunk. Her EF is now totally normal, and heart rate is 62 beats per minute. Blood pressure has increased with guideline medical therapy, and her NT-proBNP now is 93, which, of course, less than 122 rules out heart failure. So very quickly, just the evidence between combining beta blocker and ivabradine. It actually comes with a lot of evidence-based medicine. Can you combine both together with beta blocker? Which comes first? Do you maximize the beta blocker and then add ivabradine? So some practical questions. So this is an old study published in ACC and presented in ACC, in 2015, Bagri's group. And these patients used upfront combination with beta blocker and ivabradine versus carvedilol alone. So those patients that received the combination very early, within 5 weeks, actually had a significant reduction of the heart rate compared to carvedilol alone, which is something we expect. But what else happened? Those patients that gave the combination early had an almost doubling of the improvement in 6-minute walk from 62 to 116 meters. Very significant improvement in functional capacity. And not only that, because the resting heart rate was lowered and the cardiac output and stroke volume was increased, the patients were able to tolerate even more carvedilol, did not limit the uptitration of carvedilol, and they were up to 70% of the patients were able to achieve up to 50% or more of the target dose of beta blocker. So initial combination allows you to reach your target dose of beta blocker and additionally improve the patient's function even more. Ejection fraction improved significantly with carvedilol ivabradine. Of course, it improved with carvedilol, but at 5 months, there was a 10% improvement in ejection fraction. A more recent study, which was just published in 2021, just about a few months ago in the ESC journal, answers this question: simultaneous versus sequential addition of ivabradine and its impact on heart failure outcomes. So they actually looked at this prescription pattern in about 1,800 patients with HFrEF. 465 received ivabradine and sacubitril valsartan, and some of them received the ivabradine first, followed by sacubitril valsartan, the minority received the sacubitril/valsartan first, followed by ivabradine. So you'll see here, and this is fascinating really, that those patients who had sequential therapy with one before the other, or the sacubitril/valsartan afterwards, or ivabradine first, it seemed to have a significant difference in the baseline heart rate and at first initiation and addition of the second drug. So eventually these patients will reach 70 beats per minute. In terms of ejection fraction, this is really important. Using this rapid sequence addition of both at the same time, there was a significant improvement of the ejection fraction compared to the baseline. And diastolic volumes also significantly improved, as you expect the ejection fraction improved. So in context, then, there is a better outcome with simultaneous initiation of ivabradine with beta blocker and valsartan sacubitril than waiting and sequentially improving the patient. The time to cardiovascular death or heart failure rehospitalization, see in the dotted line, is really an important difference here. And I think it's really important, if you do it first, second, you really need to think about this. Simultaneous initiation is better than sequential initiation because you're saving time in terms of the patient's follow-up, and you have a significant improvement in cardiovascular outcomes. Now, if you looked at the groups of patients based on dosage or disease-modifying therapies, ACE inhibitors, ARBs, and ARNI were very well represented, as well as mineralocorticoid antagonists. And in the study, the majority of patients were able to up-titrate to the maximum dose of sacubitril/valsartan and MRA within the second and third time points. More importantly, what about the effect of beta blocker? So those patients who received ivabradine were able to achieve more than 50% of their target beta blocker dose in a greater proportion of patients after the baseline than patients who started on beta blocker alone. So again, proves the old study and gives us a very useful context. So therefore, the conclusion of this study, which we can apply in practical terms in symptomatic patients with HFrEF who need ivabradine and sacubitril/valsartan simultaneously, then sequentially, would be a better strategy to produce further cardiovascular death or heart failure hospitalizations and better LV remodeling. So there is a lot of data about LV remodeling. We've seen that with the Entresto study, the valsartan sacubitril, prove and evaluate. Clearly, if you use valsartan sacubitril at an early stage, and these are sometimes treatment-naive patients, but a good number of patients had an increase of EF by 13%. We also have similar data from the SHIFT ECHO study. The SHIFT ECHO study, again, looked at a subset of the SHIFT study, and they compared ivabradine to placebo and on therapeutic and guideline medical therapies at that time. Of course, at that time, valsartan sacubitril was not approved. Significant improvement of the left ventricular systolic volume index, significant improvement in the ejection fraction in those patients receiving ivabradine on top of beta blocker. And this was, of course, very well correlated with a 50% reduction of the heart rate with ivabradine compared to placebo. So heart rate reduction with ivabradine on top of beta blocker had some impact on LV remodeling, systolic dysfunction, and progression in heart failure. Combining these therapies, again, let's remember, our focus should not be on the water. We should be talking about the pump. This is a very important but very quick case, 34-year-old military officer, initial abnormal ECG with LVH, EF initially, 29%, high NT-proBNP, again referred for an ICD. Blood pressure was a little bit low, heart rate 61. But this patient, at the time of evaluation, was already on maximized medical therapy. He had early combination medical therapy, early maximization, and the bisoprolol was 10, ivabradine 5, valsartan sacubitril 200, and spironolactone, no diuretic. Early combination with maximization. We repeat the echo 3 months later, and you see this is at the initial evaluation, May 2019, before medical therapy, EF of 30%, dilated left ventricle, frequent PVCs. May 2019, short axis view, again, you see the dilated ventricle. October 2019, the EF has normalized 54%, and the chamber dilatation has reduced, LV mass index as well. Short axis view is very convincing. So I think this is the conclusion. Why are we waiting? There is no time to lose for our patients with heart failure, reduced ejection fraction, and heart rate greater than 70. And this is a picture I've borrowed from Professor John McMurray. These are the empty chairs in your cardiology waiting room, these missing patients. What happened to these missing patients? Have they sustained a death? Have they been admitted to the hospital? We have a simple vital sign, a simple tool that we can use to detect these patients, and multiple therapies that we need to use in combination early to protect and treat our patients. And thank you for your time.
Thank you very much for these excellent presentations. Please put in the questions into the question and answer or chat box, whatever is available to you, because I haven't seen many questions come up. Let me start with the first question, so until we get some more questions. There are so many medications now, as you mentioned. What is the optimal time of getting up to the target doses of all these medications? Over what sort of time period?
Well, I have a first stab at that. I think it depends on the patient in front of you. Many patients now are already on an ACE inhibitor because of diabetes or hypertension when they come in with heart failure. So you're already halfway down the track. And what we do is that obviously we diurese them. We introduce beta blockade very early. They have Aberdeen prior to discharge, just to get the maximal heart rate control at that point. We're rapidly moving to the same position that sacubitril valsartan is our first choice, but we're slightly restricted by the cost of that. But we move early. And to be honest, we fire an SGLT2 inhibitor during that hospitalization. So a lot of therapies go in. I think your question, though, it's really important to not keep saying there's so many tablets, because as soon as you say that to the patient, they go, oh my God, this is a problem. What we say to them is we have a whole range of different tools to help you, and we need you to get onto them as quickly as possible. That means that they don't complain about the number of tablets. They're more like saying, why am I not on the ones I should be on? Why are you waiting? So I think the language is really important with the patients and the GPs as well.
Excellent. I have a number of questions on ivabradine. If you have a patient that comes in who requires inotropic support, do you stop the ivabradine or continue it?
Yeah, we don't stop the ivabradine. We'd continue with that. I think if a patient's on a beta blocker, of course, then things like dobutamine, etc., don't work terribly well, and you have to use things like levosimendan, etc., or inoximone instead. So we often reduce the beta blockade, but not, we try and keep some of it in the background because we know patients will do better. So you have to play it very carefully, very cautiously, thinking about the pharmacology and the physiology, but we tend not to stop the ivabradine. And in fact, we often add ivabradine to these patients because many of them have an inappropriately high heart rate. You drop it a bit, you actually increase cardiac output. So we kind of do an N=1 experiment, but I'm sure Hani also has experience of this as well.
Yeah, so I think the the whole thing is when you approach the heart failure patient in the hospital, we approach with some clinical analysis, right? I mean, the whole issue is, yes, I've gotten my diuretic dose correct or whatever, but now I'm going to look forward and see what can I do right now. Now, the benefit of being in the hospital is the nurses are checking the vital signs every 48 hours. You have labs every day, so it's really a very powerful time to make these adjustments. So I would say if the patient's heart rate, and I've never really seen a bradycardic patient in heart failure. I mean, those ones already have bradycardia by this time will probably be considered for a device for some reason, either a CRT or something like that. So I think the early sequence combination in the hospital is actually a safer mechanism. We saw this with the Pioneer study with valsartan sacubitril, right? So I think it's very reasonable if a patient is under your care, that valsartan sacubitril, you got to monitor the blood pressure, you got to monitor the diuretic dose, you got to monitor the electrolytes. Ivabradine plus beta blocker, you're basically looking at the heart rate. And it's not a very difficult thing, especially if you have your patients on telemetry.
Excellent. Is ivabradine safe during pregnancy?
Why the off-label questions? There's so many patients who need to be out. Why do we go to off-label every single?
I'm just showing you the questions.
I know.
Then they tell me I'm not asking the questions that I've shown.
No. I think the official position in the UK is there's no evidence about that, and to bear it in mind if you've got very sick patients, risk and benefit, and make sure the patient's aware. I think if you had a patient who had very bad heart failure in pregnancy, that's complicated and will have lots of input. And I think everything then is off-label. And it's a question of just trying to find and navigate your way through that space and recording why you're doing what you are, the reasons behind it. Yeah.
So why is the heart failure patient getting pregnant in the first place? I think one of the key points we miss also in our younger female patients is the need for contraception. I think those things have to be highlighted.
Yeah, unfortunately, in this part of the world, we don't have a chance to do pre-pregnancy counseling. They usually come to us in the second trimester of pregnancy, and you have to treat them at that point. There are 3 questions here, all similar, even though it wasn't the subject of our talk about the SGLT2 inhibitors outside of diabetes. Basically, when and at what point should you start?
Yeah, well, NICE in England has just recently come out with a statement saying if you've got an ejection fraction below 35% and still got symptomatic heart failure, the specialist team should be starting it. And right down to an eGFR of 30 and possibly even below. So now dapagliflozin, it's the only one that's got NICE approval at the moment, is being fired into every single heart failure patient in hospital. And in clinics, it's probably 4 or 5 patients every single clinic that we counsel for this. And because the side effect profile in a non-diabetic is virtually the only problem is thrush, then most patients will accept it. So there's massive uptake now of that SGLT2 inhibitor in British practice. And I think that's the same in many countries now that have access. But I don't know about the Gulf. What's happening in the Gulf?
The SGLT2 inhibitors are actually approved in the UAE for heart failure as a specific indication. Dapagliflozin has gotten this approval as well. People are still adding this, but I think it's been a very important adjunct. We've advocated for its use as soon as the DAPA-HF trial did come out, because I think we have a lot of very sick heart failure patients. So the utilization has been quite rapid. The uptake has been very efficient. We also warn people about reducing the diuretic dose. Potent diuretic dose, adjustment of diuresis becomes important. People are often on over-diuresed in clinical practice. So when you add it, decrease the dose of diuretic quite liberally.
Yeah, and interesting to see also the DAPA-CKD data that came through, which has also led to FDA and now EMA approval for this for patients who have long-standing chronic kidney disease and microalbuminuria with a big impact on cardiovascular events. So I think the SGLT2s are almost like the new ACE inhibitors on the block. They seem to be beneficial for vascular disease in a very broad spectrum. So I suspect we'll be talking more about that in the future.
What about the use of ivabradine in right-sided heart failure?
Yes, it's an interesting question. We don't really have good trial data. My own anecdotal data, and it'd be interesting to see what you've experienced also in practice, is that heart rate is actually a good marker of outcome for most heart failure patients, irrespective of etiology. And for many of the right heart failure patients, there's actually LV dysfunction that's driven that through pulmonary hypertension and secondary right side problems. So I think there is benefit for heart rate control for those patients, although I accept that they do badly and it's not a great improvement, but I think it's something that's still important to consider.
Can you use ivabradine in atrial fibrillation?
Well, you can use it, but it's not going to make any meaningful difference. So you're wasting your drug. In humans, the evidence is it only acts, as Hani said, on the IF channels in the sinus node. So it's not worthwhile using in persistent or permanent atrial fibrillation. I think if your patient occasionally has short bursts of AF, it's still worth using. And lots of those patients were in shift. And we know that the outcome is so much better with heart rate control. So I have seen some physicians say, oh, I did a 24-hour tape. There was 6 seconds of AF. I'm not going to use ivabradine. That's nonsense. You should use it. If the majority rhythm is sinus rhythm, you should be using ivabradine.
Any preference of particular beta blockers with the use of ivabradine?
I don't know what Hani does, but I generally use bisoprolol because it's once a day rather than carvedilol, but that's just a convenience thing. I'm quite happy to use bisoprolol, carvedilol, and abibalol. What I don't use are things like atenolol or propranolol because the evidence in heart failure is not there, to be honest.
And I think the other thing is the guidelines specifically tell us about metoprolol, the long-acting metoprolol. You cannot use regular low pressor in heart failure. There has a specific label and clinical indication, but we tend to use bisoprolol because of the once-a-day convenience, and it's less renally metabolized. So I think it just gives us a little bit more flexibility.
Yeah.
And the bisoprolol is more approved in HFpEF patients, but from the senior study, there was a small group of patients that had the heart failure with reduced ejection fraction, although not very reduced. So I think that's also reasonable.
Yeah. It'd be interesting. I don't know if I can ask my own question to get you guys' input, but this concept of HFpEF, I don't like it going right the way down to an ejection fraction of 40%. I think that it's below 50, it is HFrEF. It might be milder, it might be more severe. And then the HFpEF is truly normal ejection fraction, 50, 55% and above. But I think if a patient comes to you with fluid retention and an ejection fraction of 48%, that's HFrEF, and we should treat them with the whole HFrEF armamentarium. Am I too extreme though? What do you think?
Well, I think you're 100% on. The fact is, once the ejection fraction starts to drop, it's a numerical number, and it can vary. But the remodeling has already started, and RAS blockade is the center, the core therapy here. And people have a lot of discussions about the Paragon study, but clearly those patients are stratified into very normal or above, or less. And I think if it's less, you need to give them medications that prevent remodeling. So that's been sort of my own personal approach, because I've seen patients progress very quickly, from 48 to 30, and this is reversed by combination therapy with RAS blockers. So I throw the kitchen sink. Once I see the heart failure, you got to treat everything. That's it. You have no choice. There's actually a brilliant opportunity. Your question is really outstanding, to arrest the progression of heart failure and prevent advanced heart failure in younger patients.
Yeah, I agree.
That's an interesting point, but why have some of the guidelines taken the cutoff of 45 or 40?
Yeah, it's interesting if you look across the world that there are different cut points, different guidelines. And I think a lot of it relates to the early heart failure trials, took a 40% cut point. Now, that was a pretty arbitrary cut point, but they wanted nobody to say this isn't heart failure. So they chose a very low ejection fraction. Then, of course, the evidence base is only there. So some of the guideline writers said we can only say confidently about 40%. I think our last 5 minutes of discussion was, I think we are very confident right the way up to the normal range. That is still HFrEF. And the trials now, of course, they fill it in, but they're kind of slightly behind the curve in their definitions of heart failure and the way we look at it. So I think there's a slight difficulty if guideline writers are too legalistic about ejection fraction cut points. They need to give us that clinical scope. And clinicians, I always say, I was at NICE for 4 years, guidelines are guidelines. They're not tram lines. You follow them most of the time for most patients, but you've still got to be a thinking clinician, thinking about biology, about pharmacology, about the patient in front of you. And I think hopefully people are sensible about this rather than legalistic.
I think the hard cutoff point is mostly for ICDs, right? The implication of an ICD with an EF of 40% is very clear. Absolutely nothing if the EF is above 35%, unless, it's a very unique scenario. But for pharmacotherapy, there's almost like a linear gradient. And I think what happened in the US, the FDA just gave a label approval for valsartan sacubitril with a very wide interval of, ejection fraction, with the recognition that clinicians have to make that decision in addition to other things, not just based on EF. So
yeah. And I've seen data, it's the same for candesartan, it's the same for spironolactone, it's the same for sacubitril valsartan, that you have greatest benefit in very low ejection fraction, but the benefit's there right the way up, 55% probably. So I'm really pleased the FDA was pragmatic about that and sending a strong signal, think about the heart failure, don't be too legalistic. This seems to be a spectrum, use your clinical sense. I think that's very sensible.
Excellent.
Not much about heart rate, though. We'll need to ask a few questions about heart rate.
I think we covered everything with regards to the heart rate. The AF question keeps coming up, but we've answered that one. Non-ketotic acidosis with the SGLT2, was it much of an issue?
Not in patients that don't have diabetes. We looked at the DAPA trial, not there. We looked at it in routine practice, not there. It is, however, of course, if you've got difficult to control type 2 diabetes and you're using insulin as part of the equation and you're insulinopenic, then SGLT2s do increase ketone levels. So if your patient has diabetes, you do have to warn them that there's a small risk. Non-diabetic HFrEF patient, it doesn't seem to happen. So it shouldn't be used as an excuse not to fire it into the patient.
And actually, just to give some clinical context into this, we've sort of been using the SGLT2 inhibitors in our heart failure patients and diabetic heart failure patients for a good period of time now. And we went back and we've actually found only 2 patients who actually had this confirmed. And one of the reasons for this one patient actually who was on a stable dose ended up in the ICU with acute cholecystitis, was put on the fasting NPO regimen. This medication was not recognized to be something to stop. They stopped the metformin, but not the SGLT2 inhibitor. And the patient had this euglycemic ketoacidosis. Pretty bad, I have to say, but it was picked up quickly in the form of acidosis and was treated properly. So I think this is just for when patients are admitted to non-internal medicine services, sometimes this will happen because of the lack of recognition of the this specific agent and this specific complication. But it's really under the care of medicine and cardiology, we really haven't had any anecdotally, we haven't had any real clinical issues like that.
Prof. Cowie, you're an expert on AI. Give us a glimpse of the future of the use of AI in heart failure.
Yeah, so, AI is already in practice for image interpretation and taking the slog out of calculating ejection fractions from CMR imaging, from echocardiography. It's already there for CT scanning. A lot of it is now AI and machine learning behind it. ECG interpretation, Cardia device, the Apple Watch, they all use machine learning. So it's already here. Heart failure specifically, I think it's more likely to be used in terms of trying to risk stratify better. So using multiple streams of data that are high velocity, high volume to help make better decisions about risk. Maybe helping in diagnosing heart failure in patients in the emergency room, using the data that's available to help less expert physicians have a higher index of suspicion. So those are where it's likely to start being used. But the real 5-10 year horizon is when patients start using wearables more. So we can actually integrate almost continuous streams of real life physiology into the electronic medical record and our background imaging and biomarkers, and then only flagging up to us when we think the patient may be decompensating early. That's the future. It's not here yet, but I think it will happen. And I always say to physicians who always say, oh, AI, it's terrible, we're all going to lose our jobs, there's nothing to happen. AI is only there to supplement the human intelligence and the actual decision-making process. Doctors that don't use AI will be challenged, but we'll always still need the physician's role there. So to have a kind of slightly more positive attitude towards these changes, which are part of modern life.
Excellent. An interesting question. We in clinical practice, we see patients, they come in with hypotension. We have to reduce their medications. We have to reduce their dose of ARNI, beta blocker. What do you guys do when this happens? And obviously, it's a poor prognostic sign.
Yes. I mean, it's quite interesting. And I think the problem is that when your patients get seen by other teams and they don't realize that they've always got a systolic blood pressure of 90, that's normal for them and they've had it for the last 3 years, but they go into hospital, they're not well, and they suddenly get saline infusions and all their drugs get stopped. Mm-hmm. And then they go into pulmonary edema and the whole thing spirals out of control. So I tell the patients, this is normal for you. Tell the team, this is normal for you. And that stops that happening because, as you know, once the drugs are stopped, it's very unlikely they're going to be restarted or used properly. The only exception to that, of course, is, the real cardiogenic shock, renal failure syndrome, where that is difficult medicine. You do have to back off some of the therapies. You have to rescue the patient and then reintroduce them and say, why did they decompensate to that extent? But that's where it needs to be flagged up. And the real problem is when heart failure patients go in and be looked after people that are not used to heart failure, it's often a complete disaster.
I totally agree. I think the whole point is that the patient's steady state heart rate and blood pressure should be documented in their note. We tell the patients 100% of the time, don't worry about the low blood pressure. You feel great, right? I feel much better.
Yeah.
Your ejection fraction is improved. So we try to communicate. Of course, sometimes they end up in, as you mentioned, non-cardiology services or non-internal medicine services. We get into this issue. Of course, it is important to recognize the cold and wet phenotype when a patient is tachycardic, congested, low blood pressure, lower urine output. That's a patient needs advanced therapy. They're going to get a Milrinone infusion, maybe a PA catheter, start listing for transplant. And, those are completely different than the patient walks into the, emergency room complaining of a gallbladder problem and a low blood pressure, and now the anesthetist is worried. So it's really about consultation and not being worried about the medication dosing. The other thing is, of course, from a nursing standpoint, we do frequent education on this. Our inpatient nurse coordinator educates the other nursing staff. Blood pressure is low. Is the patient symptomatic? Don't hold the next dose. The patient's doing fine.
Excellent. With all this increase in the use of new treatments, has there been a reduction in the use of ICD, CRT, transplant?
Yeah, it's a very good question, because what we've seen across the trials is the risk of sudden death with modern therapy is really very much lower than it used to be. And I think there was a nice paper in the New England Journal showing that across the last decade or so. So if you use sacubitril/valsartan, if you use beta blockers, Aberdeen, etc., use SGLT2, the risk of sudden death is reduced dramatically by those agents. So that's an important thing to remember and to remind patients and device implanters. But I think there are still patients who the heart failure is well controlled, but they are at risk of sudden death. And if they're particularly in the younger end of the spectrum, particularly if they've got coronary disease, particularly if they have scar in the ventricle, even with good medical therapy, the risk of sudden death being their exit is still there. And that's where we counsel patients and still use ICD or CRTD therapy. So it's not gone away, but I think people do need to realize that these drug therapies also reduce the risk of sudden death, importantly, as a strategy to do that. And then also to think about the patient. If they're 85 with multiple comorbidities, sudden death is unlikely to be the main exit, or if it is, it's quite a kind way of dying, as opposed to drawing it out with malignancy or heart failure. So that's where I think taking the randomized evidence, the guidelines, but the patient in front of you is where the skill of being a clinician is really still hugely important.
I think the point about ICDs is very well taken. We will always now repeat the echo after 3 months of GDMT. And now we're also using cardiac MRI fairly liberally. If the ejection fraction still meets criteria, ICD is obviously still warranted, but I think a majority of our patients is shifting their ejection fraction. This is the new thing. Because of multiple agents that have impact on ejection fraction, we're actually seeing these really hyper responders or mid responders, but large number of patients who come referred, the EF is improving. But still in the advanced heart failure clinic, we have patients, and if they meet the criteria, they need an ICD while they are waiting, because again, we can't totally eliminate the risk of sudden death if the EF remains reduced.
Can you use ivabradine in patients who don't tolerate beta blockers at all?
Yeah, and that's where they should be used almost immediately, because there's no other heart rate controlling medication. So yes, 10% of patients in shift with that characteristic. And in my specialist practice, it's about 20% of patients cannot tolerate any beta blocker. And they definitely need ivabradine, because they will not be going slow if you don't give it to them. So absolutely, ivabradine can be used on its own or in addition to beta blockade across the spectrum.
I think we are running out of time, and I'd like to thank Professor Martin Cowie and Dr. Hani Sabou for excellent presentations and coverage of heart rate and all other features of heart failure. I'd like to thank Servier and thank the Gulf Heart Association, Emirates Cardiac Society, and hope to see you soon live in person in the future. Thank you very much.
Thank you.
Bye-bye.